Hello, everyone, and welcome to today's session, Pressure Injury Prevention No Longer a Mystery. My name is Maria Lopez, and I'm the Marketing Director at Mölnlycke. And before we get started, please submit your questions by typing them into the chat, and you may submit them at any time. We will collect them and address them during the session and also at the end during the Q&A portion. I'm very pleased to introduce our guest speaker, Charleen Singh. Charleen is a surgical nurse practitioner and educator who enjoys researching about innovative approaches to wound ostomy and continence care. She has published in several journals and a wide range of topics related to improving the outcomes for people. She started her career more than 25 years ago in the neonatal ICU at British Columbia Children's Hospital. Then she moved to the US and spent almost 15 years at a children's hospital where she developed the role of the pediatric CWOC nurse. She now practices across the age spectrum at Cottage Hospital and teaches with UC Davis Betty Irene Moore School of Nursing and San Jose State University Wound Ostomy Program in California. Recently, she founded the International WOCNEP, a nonprofit program in collaboration with Ho Chi Minh Medical Center and University in Vietnam. Welcome, Charleen.
Thank you for having me. I'm really excited to be here and to talk about pressure injury prevention, especially because this Zoom session is in Canada, and that's my hometown. So I'm very happy to be here, and thank you for everyone for joining us. So before we get started, I need to go through a disclaimer. So I am being paid for this presentation, and it's not to take place of any medical advice, but these are just presentations of my thoughts, my ideas, research, and what I have found to work. So again, I need to take a moment out to say a huge thank you. I'm very proud to be a graduate from the UBC Nursing School back in 1997. And then I worked at Royal Columbian as one of my first per diem positions in the neonatal ICU and the special care nursery and neonatal ICU at BC Children's. I grew up in Burnaby, so being able to do this talk today just, it's really full circle when you're able to come back and present knowledge that improves outcomes and can possibly make a difference in a nursing evidence-based practice. So huge shout out to where I've come from, and thank you for all of my professors who pushed us to always be looking for that evidence in nursing practice. So my journey is a little bit interesting. I first left BC Children's. I wanted to experience what it was like to work in the US, and it was, very different at the time. My best friend was going to come with me on my journey. We were going to go work at Seattle Children's. I went and she didn't come, but so I continued on, and then met my life partner and settled in San Jose, California, and worked at Lucile Packard Children's Hospital at Stanford for over 14 years, and had really an incredible career there, working in the neonatal ICU, telehealth, pediatric ICU. And then during my time, as I transitioned out of primarily just being in the neonatal ICU, I was approached by, at that time, the pediatric surgical nurse practitioner, and said, there is a need for wound ostomy continence nursing in pediatrics, and would you like to start that? And so I was going to be the first nurse, wound ostomy continence a practitioner. And so I said, yes, I'd love to try that. At the time I had 2 small children, and I thought it would be a less stressful kind of role. That's what I was thinking. And as I jumped into the role, I realized very quickly that this is going to be a much bigger role Right. Someone's laughing. Yes. Right. Very. I thought it was going to be, but quickly realized this is a much bigger role. So I trained at Emory with their wound ostomy continence program. And at that time, there was no online options. It was, textbook and traveling back and forth. And then, really kind of launched me into realizing that in order to be a wound ostomy continence nurse, you do need your master's. Went through the master's program and then realized, actually, I need to be a nurse practitioner so I can write orders and really direct the care and collaborate with nursing, as opposed to nursing always trying to explain to medicine why we need certain things. This way I can really partner. And that eventually led to the PhD as my interest in understanding and doing research grew. So like I say, very interesting kind of career. Very fortunate that I had supportive people around me, because like as some of you put up your laughing emojis, it's a lot of work and we don't realize what we're getting into when we get into this. So currently I'm faculty at UC Davis Betty Irene Moore's School of Nursing, and then teach wound ostomy at San Jose State, and then now the International WACNEP, because like all of you probably experienced this, nurses all over the globe need the specialty knowledge of wound ostomy and continence. The impact on humanity is huge, and the lack of us is felt even greater. So I have 3 learning objectives today. One is to understand the evolution of pressure injury prevention. And I need to give you that background about who I am and where I came from in order for us to talk about the evolution of pressure injury prevention. And then 2, we'll touch on the impact of nursing practice. Many of you who are joining today are very familiar with this. And then lastly, we're going to go over what I like to refer to as a pressure injury prevention bundle. And the language is becoming more prevalent in the literature as well. So I hope I'm sharing pictures with you. These pictures are from 2009-10. The picture where I don't have the eyes blotted out, this family has said that, I can use the pictures to help educate. But these 4 pictures are really my why of why I pursued my master's, why I went on to NP, what kept me going while I was raising 2 small children, working full-time and going to school. It was these incidences. At the time, we had at Lucille Packard Children's Hospital, we had this incredible chief nursing officer, Pam Wells, and she called me into the office one day and she said, we have pediatricians saying that there's bed sores on the back of children's heads. And I was new to the role, but I was also an ICU nurse and a PICU nurse. And I was like, well, what are they talking about? These kids weren't even supposed to survive or make it. So as any ICU nurse would say, I was busy trying to save their lives. I don't know about the skin issues. And this was 2009, 2010. And I said, okay, but let's now in a different role and having kids of my own, I was like, this is awful. This is awful that we are scarring children, that they'll go through the fight of surviving whatever it was that brought them into the ICU. And now when they leave us, they will either have a scar on their forehead, hair loss on the back of their head. And being an acute care nurse, I had no idea what the healing trajectory was going to be like for somebody who developed a pressure injury. But as I learned, I was like, this is awful for the family that this continues. And one of the troublesome areas that we had was CPAP, or mask non-invasive ventilation. And for us in the US at that time, there was the initiative to prevent ventilator-acquired pneumonia from being intubated. And there was a big push to then go towards the CPAP, the BiPAP, the mask. And what we learned is that pressure, just device-related pressure, causes a lot of pressure injuries, which pushed us to figure out how are we going to prevent these. And at that time, there was very limited resources on how we were going to prevent and what we could do. So these are just a couple of pictures of the children that became my why I went into pressure injury prevention research, why I wanted to really devote my attention and energy into this, was because I wanted, one was I didn't want families to have to go home and be like, my child is alive, but, you know, I wanted that but to be taken away. I wanted a child to look at themselves in the mirror, recognize that they survived something, but not see that visible scar on their head or on their ear, or have permanent disfigurement from this. And for the nurses, I wanted to give them interventions that they could implement so that they can do what they're so good at doing, which is supporting the families, saving lives, and not have that but at the end of it. So that is my why. But this is where we started, right? This is where we recognized that this was becoming a problem. It was always there and getting worse as the technology improved to save lives. So as we've had better ventilation, we had better IV access, we had better central lines, we figured out disease processes, kids who were not supposed to survive were surviving. And for nursing, we were just playing catch up because we measure so many different buckets of wellness and outcomes. So the evolution of pressure injury prevention, and I've got some pictures in here that are a little bit interesting, but this is, when I look back at this, I'm like, wow, we had tall tasks ahead of us. And we've been, you know, the scholars around the globe have been trying to figure out how we're going to do this. So what did we know? We've known for a long time, since the time of Florence Nightingale, that there is a relationship between pressure and time. And we know that the severity either amplifies one or the other. So whether you have low levels of pressure, but extended period of time without movement, you're going to have tissue damage over bony prominence, or extreme pressure over a short period of time, or a heavy pressure load over a small surface area, so like under devices. And then we also know the intrinsic factors of the patient. So whether they are dehydrated, whether they're anemic, in the children setting, whether they have inflammation processes happening, in your older adult population, whether they have chronic comorbidities. So we know that there are internal and external factors. We know that relieving pressure by position is going to help. We have some old guidelines about millimeters of mercury and what levels will cause, disrupt blood flow and cause tissue damage. And what we've always known is that good skincare hygiene, which is the foundation of basic nursing care, can prevent a lot of issues. But none of this really was come together for nurses to have tools to manage these, or to be able to intervene in these risk factors that we know about. Like I said, my journey started in the neonatal ICU and then pediatric ICU. And at the time, we were dealing with several things at one time. We were really pushing the boundaries of ECMO. We were starting up a new cardiovascular ICU for pediatrics and neonates, so separate ICU. And we had this, now that we were watching for pressure injuries, we were recognizing that we were having high incidences of pressure injury. And that was probably the norm. We just were not watching it ever before. Around that same time in 2009 and 2010, the California Department of Public Health said, if you have stage 3, stage 4, or an unstageable, you need to report it to the state. If you don't report it, if you don't report yourself to the state as an institution, anybody else can. And so we became very mindful of checking the skin, checking either daily or as they moved out of the ICU. And I remember my CNO at that time, Pam Wells, said, we need to stop these from occurring. So I went back and looked to see, okay, we know about pressure, we know about turning and repositioning, and we should reposition every 2 hours. Well, for any of you who are have had to go and say that to an ICU nurse, or you are an ICU nurse, when someone says to you, you need to turn a patient every 2 hours, it's not a comfortable conversation. And it is most likely a very unrealistic expectation. We say that, we want it documented, but the reality is for nursing, it's a lot of stress, whether you're in adult ICU or pediatric or neonatal. And there are many instances where it is just impossible, whether you've got ECMO cannulations in the neck, whether you've got hemodynamic instability. And the last thing our ICU nurses need to hear is, oh, you must turn them every 2 hours. So I brainstormed with our clinical nurse specialist at the time. And I said, and she said to me, they need to turn them, that we need to find a way to turn the patients. And these are neonates and fragile children. And I was like, I don't think it's possible. Like, for me, having just come from the bedside, I was like, this is really not possible. And I said to her, I remember we were talking, and I go, it's almost like they need to be floating on air, but we don't have that. And this is a picture of the mattress that was on the isolettes. So I still keep this mattress because I look at it and I'm like, wow, I can't believe this is what our sick babies were lying on. Very little foam. I have a business card next to it, so you can kind of get a sense of the thickness. Now, some of you might go running back to your neonatal ICUs and PICUs to look to see what kind of mattress the babies are on. And I remember going to the manufacturer and saying, this isn't going to work. We need pressure relieving mattresses like the way adults do. And that one rep said to me, that's not possible. And I was like, well, why are you selling this with this? We need better technology in here because our babies are so sick and they can't move. And he said, well, we don't recommend you keeping them on this mattress for more than 20 minutes anyways. And I was like, well, then what are we going to do? We already had the gel. You see it in the top corner there with the pictures. We had the gel donuts, the gel pads. We had them in different shapes. But they either took the temperature, if they were cool, transient body temperature would migrate. So then we would have a cool baby, a warm gel, all these issues. The gel would flatten out and divot in certain places. But that's what we had. And then we had foam wedges, which was just not going to work in a neonatal pediatric population. And in the adult world, what did you have? Think back to 2009, 2010. Pillows, foam wedges came along, maybe gel pads, maybe not. The concept of floating the heels, and then mattresses, but still not very well understood. And so what we did was we were like, well, this common sense wise, because for us nursing, we have some common sense that we imply. And we're like, well, we can't prevent pressure injuries when we've got this kind of mattress that does not distribute pressure or has any immersion ability. And you can feel the hard surface of the isolette or the overhead warmer. And so these mattresses were bottoming out. In the adult world, that concept of bottoming out was there, it made sense. But in the pediatric world, we didn't have that concept of bottoming out. But these mattresses bottomed out. So what did we do? And I've got pictures that are coming up, but we worked on a hunch that we needed better mattresses in the ICU setting. And we just kind of guessed at what we needed, probably gel and foam technology, a good educated guess based on the theory and what we were seeing in the adult world. And so for us, we found and this is, like I say, one of the things about working at an institution like Lucile Packard Children's Hospital at Stanford. When we went to a manufacturer and we said, we think we need they said, yes, we will make this. And I got the opportunity to work with these two brilliant quality directors, Lee Thorpe and Sandy Trotter, and they said, just go figure it out. We will sign off whatever it is. Hopefully it's not too costly, but let's figure that we got to do something. And so we had a company who has since been bought up by another one who said, yeah, we'll make you some custom mattresses. And it was $300 each. And I said, well, let's try 10. I think I said 10 or 20. And then we did a trial. And we've published that work since then. And we got these mattresses onto the isolette and onto the overhead warmers, and our pressure injury rates went down to 0 on the back of the head. And we pretty much went down to 0 pretty quick. And then for the babies and the children that needed to have their necks in an extended position, we still were able to keep the rates down.
Sorry, Charlene, there's a question.
Yes.
So they are asking if the Rojo cushion can do that trick.
Yeah, like, so if you have the Rojo cushion, that's fantastic, right? It sits, the Rojo is traditionally made for the wheelchairs, but if Rojo makes them for the size of the isolette, if you do pressure mapping, it should be just perfect, because the Rojo cushion of what it disperses pressure. So it should do the trick. Yeah. So back then it was a hunch. And I'm glad you brought up the concept of the Rojo cushion, because pressure mapping was happening in adults that were wheelchair bound, and some children that were wheelchair bound. And it's Dr. Spreigel and a wonderful young lady who published wonderful literature on chair mapping. And then we have Dr. Amit Geffen, who has since been doing this incredible work on tissue tolerance and load and pressure mapping, and using synthetic tissue, putting it through the different stressors, and then using MRI technology to see how the tissue moves and responds and stretches. And this is where I call the evolution of pressure injury prevention. Nursing started off with, like, we have ideas of what's going to work. And then we have this great scientists from multidisciplinary mechanical engineering, biomechanical engineering, finance, that have collaborated around this concept of pressure injury prevention to help nursing build its evidence that we need. And so we know now that we can effectively minimize pressure over a bony prominence, depending on what kind of surfaces we use. This is just some of the wonderful kind of imaging that is available to us. And if you look at the areas that we were having problems, such as underneath devices on the face, you can see with this modeling, pressure mapping, heat sensing, you can really see where the pressure points are going to be, and then how you can offload them. So with devices on the face, we are able to offload pressure by alternating pressure points and using silicone-based interfaces. As well, we can go one step further and say, oh, we have microclimate on the skin. And so if we reduce the heat, if we reduce the moisture, we can also help the skin maintain its integrity. And one of the ways to do that is to use foam. Whether you use foam that breathes, whether you use foam that moves moisture out to the air or the surface, we know that we can effectively measure it, and we can say with confidence that this is going to work underneath the device. Moving on to the back of the head, the sacrum, or the occiput, the sacrum, where those loads are heaviest, again, we've got really nice science that can help us understand how to offload the pressure. Where you see the red is usually more than 100 millimeters of mercury of pressure. If you think about taking a manual blood pressure cuff, what that feels like to come up to 100 millimeters of mercury, we know that when we have high levels of pressure, that's when we're most vulnerable for skin breakdown. And if we're on that right support surface, and we also address the microclimate of the skin, shear friction forces, we can further eliminate the impact of the pressure. So this is what is really available, what is available to us now when we're looking at products. The research has been over the last decade. We've got wonderful collaboration between nurse scientists, clinical practitioners, and then again, this great world of engineering that can do a lot of modeling and predicting, as well as then tying it together with the economic piece of it to say, oh, something may seem, a nursing intervention may seem costly today, but if you take it out over the long term, there's actually going to be quite a bit of cost savings. And so this is really something that's been exciting for me, is that it's the evidence-based practice that we need, and we no longer need to be thinking or trying to figure out how to prevent pressure injuries or maintain skin integrity. This is probably one of my favorite pieces of technology that's available to us. And I want to just kind of point it out that back in 2010, 2011, when we were looking at the concept of pressure mapping in pediatrics, we reached out to a Canadian company out of Alberta, Exensor, and they built us our first map, which I still have. And it was validated and reliable down to 10 kilos and less. And then we had our wonderful young lady who's at Tufts University doing her master's in mechanical engineering, Ms. Heiger, who then did a pilot study to see which product really disperses pressure and relieves pressure. And then when you look at Dr. Geffen's work, he ties it together with what do we see on the surface, right? What do we see as nurses? And we see this incredible deep tissue injury that looks like it's going to probably evolve to unstageable. And then you've got the modeling up here of the anatomy. Where is that bone? Where is that pressure? How is the patient positioned? And this is a part that I love, is that the modeling of, okay, which intervention works? What's good? What's most effective? Besides, other than we know we need to turn and offload pressure. And now we can layer nursing interventions and then test it to see if it works. So if we offload pressure by turning and repositioning, we have a bordered foam that is able to pad, wick, absorb, and protect from shear forces. What will that look like with a certain amount of force or pressure that's still applied to that skin? And what will happen if you don't do those nursing interventions? I think that's the other piece of it. What happens when we don't, and what will happen if we do? And so this is really great work. I say to different clinicians that ask me that they want to do a trial to see if something works, I say to them, for pressure injury prevention, you can look at the literature and see what's there. And then you don't need to do a trial to see if it works. You can do your trial to see how it's going to work with your staff, because we've already done the science part of it for you. It's out there. We know what works. And if you look at the literature, you'll see what works. So when you do your trial, the conversation of the trial changes a little bit. You are more focused on the implementation of the intervention during your trial. And these are the little nuances. Are the products where the nurses will find it? Is the product easy for the nurse to use? Will your patient population like it? You can really focus on the systems and processes and not have to worry so much about the outcome of, is it going to work? And that all of those steps take a lot of time and energy, and then you can move your focus to where you need it to be. So what is the impact for nursing? I mean, I think all of you, just by seeing some of the little emojis that popped up, I think for all of us, we know what the impact of PIs is. First of all, it's devastating statistics across the age spectrum, right? I was looking at the Canadian Institute for Health and Information, and it looks like you input your data there, and rates vary, anywhere from 15 to 30% of incident rates from stage 2 to stage 4 that are reported or entered in post-acute care settings. Acute care settings as high as 23, 24% with no interventions implemented. Our rates are still, when there's no interventions implemented, it can be as high as 28%, if not more. The pressure injuries over the heels, I find shocking and devastating how it can alter the life. So I tell my nurses, we have elderly patients that come in for pneumonia into the hospital setting. Usually it's the pneumonia, the acute respiratory distress that brings them in. And discharge happens pretty quick. So once we get them out of this acute phase, they go home. And that's when their pressure injury over the heel will appear. It may be a little bit of erythematous over the heel while they're still in the acute care, may evolve into a deep tissue injury while they're in post-acute. And then that full-blown necrotic tissue may not surface until they are home. And for us in acute care, we will never know that happened. But what does happen for that patient when they're back on the community, their foot hurts, they are not as mobile. This may be the little old grandma or grandpa that was independent. They putzed around, they were with their family. I always say sometimes, in some families, they are the anchor of the family. They're not a burden on anyone, but they come into the hospital, they get a pressure injury over their heel, and all of a sudden their life changes. Now they are not able to ambulate easily. They're not able to putz around and do their activities of daily living. And they may become very much of a burden to their family. Even if the family doesn't see them as a burden, they become very much of a burden. And then there's the wound itself, the pressure injury over the heel itself. Many times they don't heal. You can't get them to heal because of the comorbidities that they have. And now their last years of their life is centered around this pressure injury over the heel, which was probably preventable. In today's world, I preface that. In today's time, with the technology that we have, these are most likely preventable. And if you don't put the interventions in place, you'll never know if you were able to prevent them. Without having the interventions in place, you can't say that it's unavoidable. You need to have interventions that are evidence-based in place to prevent these pressure injuries. So then you can say, oh, you did everything that you could do, and they still develop this. From the earlier pictures I showed you, body image for across all ages. And in US dollars, the estimate is at minimum $70,000 for a pressure injury. And that's just your stage 3, stage 2, your uncomplicated pressure injuries. When you factor in cost of dressings, healthcare dollars, we're looking at, in conservative estimates, a lot of money, a huge burden. And then the other piece of it that's really important is for us as nurses, we don't feel good about this, right? We don't feel good. We may not sit there and think about it like the way you do if your IV infiltrates. But when someone presents us these numbers, it's awful to think that we've been a part of this. And all of us as nurses wish we had the interventions to be preventing these pressure injuries. So it's counterintuitive to our nursing practice. This is not something that we set out to do. This is not something that we want to do. Very counterintuitive. A huge dilemma when it comes to maintaining physiological stability and then maintaining skin integrity. I talked about the extreme case where you've got somebody who's maybe on ECMO, hemodynamically has instability. But what about our orthopedic patients where they're in traction? Or they need to be immobilized and you just can't turn them and you can't position them. So for our nurses, if we're in leadership positions, we need to give them the proper tools to be able to prevent pressure injuries. We can't come after nursing and say, you need to turn every 2 hours, you need to document, and you need to prevent this from happening. The ripple effect is that it just causes a lot of stress. Charge nurses and resource nurses or team leaders are being told to remind the nurses to turn and reposition. They're told to document, and then you've got the patient that you just can't reposition. It causes a lot of internal and team dynamic strain, because for all the nurses, they're trying to do our best. Us in leadership are trying to do our best as we report out and we reflect back on what our patient care is like. You're trying to do your best for the family, and families are trying to do their best. And if they don't have the tools, or if they don't see what best practice is in the hospital, they can't mimic that when they take their loved one home. And a physical strain, the other piece of it is, if you're working in the neonatal or the small pediatric population, the young side, there's not as much of a physical strain. But for everybody who's working in the adult world, with obesity rates increasing, or even if a patient is very cachectic, but they're very stiff, it is a huge physical strain on nursing to be able to turn and reposition patients every 2 hours. And if you have a heavy patient load, or if you do have a busy day, again, your mental burden that you need to get back there and turn somebody to reposition, that's a lot on staff. That's a lot on nursing. So another piece of it is, for us in the US, we have to report out to something called Leapfrog, where consumers, insurance companies, everybody can look at the rates of pressure injuries. And pressure injuries is considered a nursing quality indicator. But like I say, our nurses need to have the tools to be able to do their best. So on the flip side, now this is the research that I was really fortunate to be able to do. Again, I got, sometimes life is kind of a full circle. The incredible director of quality that I got to work with back in 2010, as we all moved on to do different things, she reached back out to me in late 2018, 2019. She was at a new facility and she said, this facility has high rates of pressure injury. Can you come in and help us out? And I said, okay, but now it's easy. I said, it's not like it was when 2010, when we had to go hunt down manufacturers to make us mattresses. And we were digging through the literature to be like, what's going to work in neonates and pediatrics? I'm like, it's all there now. And I go, and here's a bundle. I'm like, if the hospital's willing to implement the bundle, we can implement the bundle. And I'm pretty sure we can get these rates down. And so we have recently published this piece of the information, which was the cost, because for justifying cost is always hard. So in 2018, this particular facility had spent $13,000 in pressure injury prevention. They didn't have a lot, but that's what they spent. They had 206 pressure injuries. And they had, what's not included in here is that they had 18 reportables, right? So reportables are stage 3, 4, or unstageable. So they had 18 of those. And the theoretical cost, and now in the US, some hospitals and insurance companies are one unit. In other situations, the hospital is a separate unit. But the theoretical estimated cost of the pressure injuries in 2019 was over $2 million. All those patients went out into the community, they dispersed, somebody else is dealing with it, but the estimated cost is over $2 million. In 2019, we spent $123,000 in prevention. Our pressure injury rates came down to 54, and the estimated cost on the healthcare system is about $780,000 US dollars. Now in 2020, We spent way more because we had the pandemic. And so we had way more patients that were intubated, sedated, and immobile and high acuity. And so the cost of prevention went up to almost 400,000. Pressure injury rate still came down, 26, with no reportable, so no stage 3, 4, or unstageable. And the estimated cost of the pressure injuries that we did have was on the healthcare system was about just a little over 500,000. And so the upfront expense, it seems like it's a lot, but the savings to the healthcare system is definitely significant. And so the return on investment from the prevention piece of this is profound. This is only looking at dollar savings, right? So we've saved well over 1.5 million by just spending 380,000. But when you think about the activity of daily living, when you think about all the heals that we may have prevented, quality of life, nursing satisfaction, and then how exciting is it when you give your numbers back out to units and say you've had 0 pressure injuries, you've had 0 reportables, and so it really improves that work-life satisfaction. So in the last 8 minutes or so, I'm going to go over our objective number 3, which is how to recognize a pressure injury prevention bundle. And this is, again, so remember where we started, and I'm just going to use this quote from Walt Disney. The way to get started is to quit talking and begin doing. And that is what we did. Gives me goosebumps all the way back, 12 years ago, 3 women said to me, do something. I looked around and went, what are we going to do? I don't know. I mean, got to do something. So we did something. We found a person to make us a mattress that would fit in the isolette. They came and measured and they made it. And this is pictures. This is pictures from then. So this is what we did. I mean, this was just fantastic. So this is what the mattress that we had done. This is what they looked like. And their longevity, I want to say, was more than 10 years because I left in 2014, at the end of the 2014, and these mattresses were still going strong. So the $300 upfront investment, and I mean, that ICU was always full. There was always a baby on there, wiped down in antimicrobial, antibacterial, tolerated that wear and tear. You can see how thick that foam is. And so there was the 4-inch foam and then the gel. During that time, this fabulous product came along, and I was like, oh, we're all about this. And that's what's known today with a lot of love is Z-Flow. And that's I still can't wrap my brain around it, but that's fluidized air. And this is where Accenture from Canada, Alberta, built us pressure maps. And then this wonderful mechanical engineer made models of babies' heads in different weights. And she checked it out. Which surface provides the greatest pressure relief? And that was our fluidized air versus foam versus gel versus mattress. But when you start combining these things, such as the fluidized air, which is now known as Z-Flow, with a pressure relieving mattress, we had almost 0 pressure exerted onto the bony prominence. And then when we put our Mepilex border over the occiput, now we prevented shear friction forces, and we were able to absorb that moisture. What we did for the children, because at the time we didn't have a mattress and we didn't have a frame, and we were so, like I say, that, it's a lot of work, right? So we were very focused on this element of it, of our most fragile. We did something kind of cheeky with our kids that didn't need to be in a crib. And we put them all on adult beds, a high level pressure relieving adult beds. We just said, you know what, this is what we're going to do. And then we took a step back and we asked a company called Sizewise to do custom mattresses for cribs. And that was full circle. And then we had standard workflow, which I'm not sure if they still do this or not there. I've been gone for a few years. But in the new facility that I'm at, we do the standard process, where whenever the bed gets wiped down and housekeeping is getting the bed ready, the team leader nurse will set up the bed so that when an admission is coming, it's ready. In the facility that I'm at now, for the adult patients, housekeeping will set it up. They will bring out the tortoise, they'll get the bed ready, they'll put the tortoise out, and they feel like that they are doing more than just cleaning, that they're doing something to help the nurses, and they're directly impacting patient outcome. And so this is a picture of what it all looked like back then when we put it together. So they're on their foam, they're on their custom mattresses. They've got the Z-Flow that cradles, and then we've got the baby bunty to then provide developmental care. This is the most fragile of the fragile, and we rates were zero for a long time. So what does this timeline look like, right? Regulations around HAPPIs started to come out into place in 2007 and 2009. 2009 to 2012, we had initiatives based on existing science, but it wasn't strong enough. And then we have incredible people starting to really pay attention and put resources into figuring out the science behind maintaining skin integrity. And then there was individuals like myself across the US in pediatric facilities who started experimenting. Essentially, we were like, okay, if this works in adults and this makes sense, and if we can have someone make us something, then we're going to get it custom done and we're going to implement it. And I mean, that was everything from silicone-based interfaces for mask non-invasive ventilation, silicone-based tubing, wrapping foam, because back then it was Mepilex foam light had just come out, so wrapping foam around tubing, cutting out triangle shapes underneath the nose, getting Mepilex foam, bordered foam on sacrums. And in the years following, articles started coming out. Great literature about how to bring rates down, how to implement nursing intervention, and what the results were. And then in 2017, 2020, when you look at the literature, now there's implementation based on analysis. So we have your clinical nurse specialists looking at literature and going, if it worked there, let's do this here and let's see if it works here. And around the same time, there's nurse scientists going, what exists, what are the gaps, and what do we need to do? And that's where we are currently. What we know is that when you implement a pressure injury prevention, nursing interventions, it needs to be implemented as a bundle. You need to have skin risk assessment, nutrition, skin care, and then protecting bony prominences and from immobility. The next piece, and where I'm taking this to, with the next bit of research that I'm going to be working on this summer, is it's time to start thinking about things a little bit differently. Skincare is basic nursing care. Skincare should not be done just because your braiding indicates there's moisture issues, right? So back to the basics. Skincare is skincare, good pericare, good bathing, good moisturizing. Nutrition, it shouldn't just be implemented because we've got a risk score. Nutrition should be that basic foundation part of nursing care. What does trigger implementing the full works of pressure relief is immobility. If the patient is immobile for whatever reason, we need to make sure that the bone tissue interface is not generating enough pressure to cause skin breakdown. And so I think you're going to start to see that more so in the literature to come, is concepts of implementing things as bundles. And then let's really let's get into the detail of what needs to happen to prevent skin breakdown. So as a bundle, and I'm just going to steal an extra minute to finish up, is have your policies in place. Understand your patient population, your nurses, and have the policies in place. Step 2 is have the supplies ready to go. If nursing needs to call something up from somewhere, bring it, it's not going to work well. And then, of course, educating the staff on implementation, and then clear guidelines on when to implement the bundle. And then circling back to how. So a sample bundle looks at pressure injury prevention, nutrition, and skin integrity. Like I said, nutrition is basic. It should be individualized for all patients based on their disease, patient preference, and not just because they're at risk for pressure injuries. Skin integrity, again, basic nursing care. All patients should be cleansed with pH balanced cleansers. Everyone should be moisturized. And we have incredible products to wick away moisture from skin folds, and great products to manage incontinence. So identifying your patient at risk. Any immobile patient needs protection, whether it's they're at risk because of their surface that they're going to be in or devices. And so we need to be able to not only have the products to prevent that, but we need to facilitate position changes. And this is my go-to. It's got great evidence behind it. It works repeatedly. There's been over a decade's worth of research behind it, so I like it. Dr. Todd Brindle did the work on the Mepilex sacrum, and then we were like, wait, we can put the sacrum on the heel, and then we can put it on the elbow. So we were switching it around and moving it. And then there's my fluidized air that we used in the NICU that works great in adults for positioning. And then we have the tortoise, which again has air cells in it, help turn the patient, and then adjust pressure points. So I'm hoping for everybody that's listening, and especially if there's nurses that are young in their career, that the work that we've done before you, as we I am constantly reminding myself as I transition into leisure time, that we've laid a path for you, and we're willing to help you all along and share our knowledge with you so that you can implement your best interventions. And the evidence is out there for you. This is something that I'm hoping that you can continue to build on and not feel like you have to look for it. So thank you today for letting me share my journey of how to prevent pressure injuries, and also sharing how it's not a mystery anymore.
Thank you very much, Charleen, for such an informative presentation. And there was a question here that I already replied because it was specifically to Ontario. Mm-hmm. They were asking if there were supports in place for Ontario for medical products coverage. So I replied that specifically in the Q&A box. But there are other questions. So what were some of your barriers when implementing PI prevention programs?
Yeah, so some of my barriers, one in the early phases was not being able to find the products that was going to that we thought theoretically would work. So that was one of the big ones. The second one was buy-in from nurses, that if you just use the product, I promise you the pressure injuries will go away. That was the second barrier. And then third barrier in the ICU setting specifically, this concept of we're too busy to implement the intervention. And so that led to the concept of having the bed ready with the interventions already there. So in the adult world, the bed is ready with the tortoise. The packets of sacrum and heel dressings are sitting in the corner of the bed, and then the Z-Flow and the Z-Flex are in the room. And so that was the other big barrier. Now, the fourth barrier, which has not changed, and this is why Dr. Padula and myself and other clinicians are trying to publish this, is the finances, getting your chief financial officer to sign off on a product that seems very expensive upfront. And so that is always that fourth barrier. But the problem with the reason what happens with that is because we don't know how much pressure injury prevention costs, we don't build it into a budget. We kind of come halfway through the year and being like, oh, we need this product. And so that's the article that I had worked on, was to try to understand how much it costs and get it into your capital budget when you're in the planning phase, and not trying to get it in halfway through the year where now everyone's worried about the budget. So those were my 4 big barriers.
Okay, thank you. Here's another question. So how often was the skin below the Mepilex assessed? We have the issue that staff are not looking below the dressing and assessing the progression of the skin or wound below.
So that's a really good question. And we have debated this for years. How often do you peel back that dressing to take a look? For our incontinent patients, or our patients that are stooling frequently, or they're bedbound, it's not that big of a conversation, because when it gets soiled, it needs to be removed. They do their peri-care, they check. But for the patients who are NPO, not stooling, maybe they have a Foley in, that's where the conversation would come up. And we would say once a shift. But what we found in all honesty, what we found in our ICU with the adults is that nurses were not looking for 3 to 4 days. And we said, okay, that's fine, because we were finding problems underneath. If we were finding problems, then it would be a little bit different conversation. But because we know that the pressure exerted on their sacrum is very minimal because of the support surface, the tortoise, and the use of the Mepilex border, we are fine if nurses are not able to check, and we leave it up to nurses' critical thinking and assessment. If the patient tolerates position changes and you can peel back and take a look, that's great. If they're hemodynamically unstable, they have a lot going on and you can't look, that's fine too.
Okay, so another comment, I thought it was harmful to open up the dressings that often.
Yeah, it is harmful, because every time if you have an open wound and you peel it back and you take a look, the wound temperature drops down, and it takes another good 3+ hours for the wound itself to return back to normal temperature. So peeling back and checking frequently, like every shift, is not a good idea. Again, unless there's circumstances that's around it that you need to. When you use a product like a Mepilex border, and I use that brand name because that's where we've done all of our research, not just because it's the session, but because that's the research we've done. We know that we can leave that dressing in place for 5 to 7 days without any issues. In our outpatient clinic, we leave the dressings in place for a week. And we've been doing that practice for 4 years now, and we've not had issues. We change the dressing if it's saturated, soiled, dirty, or anything like that. But we've been going on to our 4th year in our outpatient clinic with leaving the dressing alone in place.
Okay, and a last question, because we're running here out of time. So any issues with skin damage, incontinence with sacral dressings for prevention?
No, but I can only say that for the Mepilex border, because we have not, I have on a peripheral way been engaged with other bordered foam dressings that are not Mölnlyckes, and I've seen a lot of skin issues. So it's the technology within the 5 layers of the sacral dressing and heel dressing that makes it unique, because it will take moisture, pull it away, keep it to that outer layer. It has antimicrobial properties. And so that's the only one that I can speak to confidently, that no, you will not have problems. But if it's a different bordered foam dressing, I can't speak to them.
Okay.
Yeah.
Thank you, Charleen, for your engaging talk, and thank you everyone for attending today's session. Thank you to Wounds Canada also for hosting this symposium. Upon ending this session, an evaluation link will appear in the chat box. Please click on the link or copy paste it in your browser and take the time to complete the session evaluation. On behalf of Charleen Singh, Mölnlycke, and Wounds Canada, thank you for joining us today, and have a great rest of your day.